Uh, Hello everyone, welcome back again. Assalamu alaikum. We will start the bladder tumor part 5. We will speak about stage T1. Stage T1. The management for stage T1 we will do TURBT, and resection should be deep enough to sample the muscularis propria, except when the cancer in the diverticulum, and for the tumor in diverticulum we speak about this. The restaging TURBT, the second TURBT, within 6 weeks after the previous TURBT should be performed in all patients with stage T1 cancer, even when the muscularis propria was present in the prior TURBT specimen. Immediately post-operative intravesical chemotherapy, a single dose of intravesical chemotherapy within 24 hours of TURBT, ideally this must be within 6 hours, is recommended because it reduces the risk of recurrence. Absolute reduction of 14% in 5 years recurrence. Stage T1 can only be assigned when the pathology specimen contains muscularis propria that is free of cancer. In the other words, stage T1 should not be assigned when the muscularis propria is absent for the specimens. Okay, this is when T1 only assigned, that's T1 only is assigned when the pathology specimen contains muscularis propria that is free of cancer. Okay, so very high risk T1 cancer. The following cancer have a higher risk of progression to more advanced stage. Therefore, preferred treatment for the following cancers for those high-risk cancer is early cystectomy. So we have a low-grade T1 cancers with all of the following characteristics. This is considered high-risk T1. Thus, low grade with size more than 3, multifocal, and have a recurrence. This is considered as high risk, very high risk T1. Okay, this must be underwent cystectomy. High-grade T1 cancer with any of the following characteristics: size more than 3 cm, multifocal, recurrence, which is associated with CIS in the bladder or CIS in the prostatic urethra. All this is considered as very high-risk T1. Okay, it's high-grade cancer with any of the following characteristics. This is considered very high risk of the T1 cancer. Any cancer, T1 cancer, exhibiting lymphovascular or variant histology considered as a very high risk T1 cancer. T1 cancer, if we have lymphovascular invasion or variant histology. Any T1 cancer that cannot be completely resected by transurethral approach is considered as very high risk T1 cancer. T1 cancer not very high risk for those cancers. It's actually we will give intravesical BCG generally preferred treatment for T1 cancers that not very high risk. From this slide, we know that this is high risk cancer. High risk cancer of progression of more advanced state that include low-grade T1 with these features is considered as very high risk, size more than 3 cm, multifocal, recurrent, or a high-grade T1 with size more than 3 cm, multifocal, recurrence, or associated with CIS in the bladder and prostatic urethra is considered as very high risk. Or any cancer that have a lymphovascular invasion or variant histology is considered as high risk. Or any cancer that cannot be completely resected by transurethral approach is also considered as a very high risk. All these very high risk T cancer are not very high risk, can receive intravesical BCG. But those patients, very high risk, it is better to manage by cystectomy. But if the patient is not very high risk cancer, which is T1, so it is better to manage by intravesical BCG. Induction of intravesical administered 6 weeks, induction of the course intravesical therapy starting 3 to 4 weeks after a TURBT. So 6 doses. If this fails, BCG is preferred for stage T1 tumor because it is more effective at preventing recurrence and progression than chemotherapy. Intravesical chemotherapy may be used for induction when the BCG is not feasible. 6 weeks after finishing 6 weeks induction course, prefer cystectomy with or without biopsy, bladder wash cytology to check the persistence of the tumor. So 6 weeks after the finishing 6 weeks of the induction course, intravesical BCG or chemotherapy. So we will do a cystoscopy and bladder wash cytology. This is to check persistence of the tumor. Cystoscopy with or without biopsy. If TURBT, the first 6 weeks induction course showed us high-grade T1 cancer, then radical cystectomy is preferred management. If TURBT after first 6 weeks induction course show low-grade papillary tumor or no tumors, treatment typically with the second 6 weeks induction course of intravesical BCG. This must be weekly 6 dose. 6 weeks after finishing the second course, perform cystoscopy with or without biopsy, and also perform bladder wash cytology for the patients with this T1. If 6 weeks course of intravesical therapy failed to eradicate the tumor, then the second 6 weeks not treat the tumors, we will do cystectomy is recommended. Maintenance BCG if the tumors is eradicated after 1 or 2 6 weeks course of induction therapy, then maintenance BCG is recommended. So we'll start the first dose and the second dose 6 weeks. If this fail to reduce or if the tumor eradication after this course will like to eradicate the tumor, we will give the maintenance of BCG. Example of follow-up regimens after induction of the BCG. After induction, we would like to do cystoscopy and urine cytology at 3 months post-TURBT, then every 3 months for 2 years, then every 6 months for 2 years, and then annually. Using other urine tumor marker might be options. CT urogram is every 1 to 2 years. CT urogram should also be referred when there are frequent recurrence or the patient have symptoms of cancer like hematuria, gross hematuria, or flank pain. CT urogram is preferred in the most cases, but other imaging alternatives are available. CT and MRI is also available. This is the end of the blood